Have you ever wondered about the state of cardiovascular disease mortality in California? How it ebbs and flows, or perhaps how it links to factors such as sex, race, ethnicity, and even income? Today, we delve into a comprehensive study that examines cardiovascular disease-related death trends from 1999 to 2021 in the Golden State. The pursuit of equity in cardiovascular disease mortality paints a vivid picture against the diverse backdrop of California's landscapes. Hello, my name is Dharma Bada, Senior Epidemiologist, Lead Research Scientist at California Department of Public Health.
Hello, my name is William Balmer. I am a cardiologist at UC Davis Health and at the School of Medicine at the University of California, Davis. We are here to present the findings of our recent study. The title of our presentation is Trends in California Cardiovascular Disease Mortality, Sex, Race, Ethnicity Disparity, and Income Inequality, published by Mayo Clinic Proceedings. We thank Mayo Clinic Proceedings for the opportunity to present our findings. California, a diverse and populous state, has long grappled with the burden of cardiovascular disease. In our study, we set out to uncover the complex relationship between cardiovascular disease-related deaths and key demographic factors over a span of 2 decades.
The research focused on the age-adjusted death rate per 100,000 population attributable to ischemic heart disease, hypertensive heart disease, heart failure, stroke, and a combination of these cardiovascular diseases. The data were obtained from the CDC Wonder for California, and a joint point log linear regression model was used to determine trends in cardiovascular disease death. Delving deeper, we examined income disparities using metrics such as the slope index of inequality and health concentration index. The findings are quite insightful. Between 1999 and 2021, overall death rates significantly decreased for cardiovascular disease with an average annual percent change of 2.2%. The rates are also significantly decreased for ischemic heart disease by 3.7% and stroke by 2%. On the flip side, the rates increased for hypertensive heart disease by 2.2% and heart failure by 2%. Interestingly, the age-adjusted death rate of combined cardiovascular diseases first significantly decreased from 1999 to 2014, then significantly increased after the onslaught of the COVID-19 pandemic. The rate of ischemic heart disease significantly decreased from 1999 to 2019 and then increased after the pandemic, though it wasn't statistically significant. The rate of stroke significantly decreased from 1999 to 2009, then increased after the pandemic, but was not statistically significant. The rates of hypertensive heart disease from 2014 to 2021 and heart failure from 1999 to 2021 significantly increased, and this increase accelerated after the pandemic. Furthermore, we uncovered significant disparities across demographic groups. Male individuals and non-Hispanic Black, American Indian or Alaska Native, Native Hawaiian or Pacific Islanders, and Asian populations faced heightened risk of cardiovascular disease-related deaths. Our findings illuminated stark inequities, with cardiovascular disease deaths disproportionately affecting poorer populations.
As we reflect on our findings, one resounding conclusion emerges. The COVID-19 pandemic has halted our reduction of cardiovascular disease deaths in California and exacerbated existing disparities, thus amplifying the burden of cardiovascular disease on marginalized communities. The study found increasingly adverse outcomes among the poor and racial ethnic minority populations. Understanding these trends and disparities can play a crucial role in shaping future policies and interventions aimed at reducing the burden of cardiovascular diseases, especially among the most vulnerable populations.
Our study underscores the urgent need for better overall cardiovascular risk prevention, including targeted interventions and policies aimed at addressing socioeconomic and demographic disparities in cardiovascular health, ensuring equitable access to improved care for all Californians. It's a call to action for all stakeholders to work collaboratively to address these disparities and ensure equitable health outcomes for all.
We hope that you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you will find access to information for our social media content, such as additional videos on our YouTube channel, www.youtube.com Mayo Proceedings, or journal updates on Facebook, www.facebook.com Mayo Clinic Proceedings. You can also follow us on X, formerly known as Twitter, available at Mayo Proceedings. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This content is copyrighted by Mayo Foundation for Medical Education and Research, published by Elsevier Incorporated. All rights are reserved, including those for text and data mining, AI training, and similar technologies.